today's sessions. But the first session is a free paper session. May I call upon Dr. Sri Krishna, Senior Cardiothoracic Surgeon, Director DNV Cardiothoracic Surgery Training Program at the Narayana Hridayalaya Institute in Bangalore. So this is a non-competitive free paper session where 6 plus 2 minutes are given. 6 plus 2 minutes per candidate. May I please call upon Dr. Ankit Maheshwari for his paper on thoracic surgery for post-tubercular hydropneumothorax in a patient with cerebral palsy, a case report.
Very good morning, sir. Thank you for giving me this opportunity to present this case report from our institution, Dr. D.Y. Patil Medical College and Hospital and Research Center, Pune. We had a case of thoracic post-tubercular hydropneumothorax in a patient with cerebral palsy, and we would like to present this case report. So this was going straight on to the case. This is a 17-year-old male diagnosed with cerebral palsy since infancy, with having all the features of cerebral palsy such as strabismus, spastic posture of upper and lower limbs, apart from other skeletal features, and he was diagnosed with TB and already on anti-tubercular treatment. But after 1 month after starting anti-TB treatment, he also developed pleural effusion for which intercostal drain was inserted, and he also had a history of weight loss. The patient already was weighing 35 kgs, but he was down to 30 kgs, and he had prolonged drainage and non-expansion of the lung for more than 2 months. And also, he also had air leak present, indicated of bronchopleural fistula, because even with prolonged drainage, the culture was done and the fluid culture showed Pseudomonas treated with antibiotics, and after that he was referred to our institution for prolonged drainage. So at first, the call came to us, and we were thinking of whether this patient is operable or not because of this poor general condition. So we examined the patient and we wrote a number of investigations, and radiology was done. Apart from the routine lab investigations, radiology X-ray CT chest was done, suggestive of large loculated hydropneumothorax with underlying lung collapse, and as associated with cerebral palsy, there was kyphoscoliosis and thoracic asymmetry. Respiratory assessment was done. This patient initially was unable to perform any spirometry or the PFT, but had good voluntary cough efforts, and the saturation was 96 to 100% at all times. On neurological evaluation, he was able to see, hear, and reply to multiple commands. However, he had strabismus, and he was able to pick up objects even though he had spastic posture of the upper limbs, and but sitting from lying down position could be done only with support, and he could turn from side to side, and he was able to cough out. There were muscular degeneration and spasticity seen in both lower limbs and upper limbs, and even with support he was not able to walk. So personally, at a personal level, even at home, he used to have a lot of family support in his routine work. His posture was usually sitting and bending forward, and deviation mostly to the right, even in the past before he had TB. So in the X-ray, we can clearly see a right-sided hydropneumothorax. This was, the patient could not sit for the X-ray, so it was taken lying down position. We realized that the degree of scoliosis went down. So here we can see a degree of scoliosis with cavity towards the right, but in usual sitting posture, it was much more than that. The right side of the lung is collapsed, and there is an ICD in situ. The left lung looks pretty normal. And this is the CT picture. We can see the right lung is totally collapsed with a thick peel over it. ICD drain is in situ. The left lung looks apparently normal. And our radiology friends also showed us a good 3D image, how it looks like, where we can see the right upper and lower lobe. The middle lobe is hardly seen, and the left lung is well seen inflated. So first we gave our references to a number of people for optimization. First of all, the nutritional improvement had to be done because of the weight loss, and the high protein diet was advised. The antibiotics were advised to treat the culture growth which was seen in the pleural fluid, and anti-tubercular therapy was to be continued. The physiotherapy department had to be called in. They were strictly advised to take care of this patient, especially as this was a special child. And respiratory physiotherapy, he was advised to try spirometry. A number of deep breathing exercise and pursed lip breathing exercise were given, along with attempts at breath holding and cough efforts. And the counseling was done by the child psychologist also. He was 17-year-old, and on a personal level, there was a lot of personal motivation from the patient, as he has just wanted to get that ICD out of him, and there was a lot of family support. So his initial so after all these evaluations done and having a good personal motivation, especially from the patient side, to undergo surgery and go through all the post-operative care which was told to him, we decided to take him up for surgery. As you can see, this is the position. We had some difficulties in the position, but eventually after a good muscle relaxation and intubation, we were able to position him as well. You can see the degenerative muscles, but this was much better because we had already given him quite a lot of nutrition. When the patient initially presented, his muscle wasting was much more. He was in our ward for more than 1.5 months. So we had a very senior anesthetist with us who also advised to give epidural for him because to deal with the post-operative pain, and he was able to insert a post-operative catheter as the spine got straightened out when he was lying down. So the procedure was done under spinal and epidural anesthesia with right posterior lateral thoracotomy was done. Seeing the crowding of ribs, we decided to excise the 6th rib and go through the space, and the routine procedure, the routine thing was done, which is decortication, non-anatomical partial lobectomy, and bronchopleural fistula closure. And as you can see, we have excised the 6th rib and the decortication process is on, and post-decortication, we have freed the lung from all around. Partial non-anatomical lobectomy was done, and we had, except for a very few surface leaks, there was nothing. And the post-operative X-ray, the right side pneumo had gone down a lot. The patient was extubated early after surgery, and epidural analgesia was in situ for nearly 1 day. The patient started having good coughing efforts on the 2nd day, and he was mobilized early in wheelchair, and the drains were removed on the 3rd post-operative day after ensuring there were no air leaks and no drainage. Adequate nutrition was given as it was being given pre-operatively, and the patient was discharged on the 5th post-operative day and advised to continue physiotherapy at home. So the discussion, there are a number of neuromuscular diseases such as cerebral palsy, polyomuscular dystrophies, amyotrophic lateral sclerosis, and myopathies. We have to examine all the, we have to have a good neurological evaluation such as the posture, muscle tone, muscle reflexes, muscle strength, joint range of motion, and when it comes to cerebral palsy, it is of course the most common cause of child disability. There are a number of systems involved, and the behavior can be variable when it comes to sensation, cognition, and behavior. And the literature on thoracic surgeries in this patient is really limited, with only 1 or 2 case reports. And the challenges involved are preoperative assessment, optimization, intraop anatomy, and postoperative recovery, which we dealt with individually. The preoperative assessment, the most important in mental status, whether he is able to understand the difficulty and the nature of surgery. The IQ assessment is difficult because initially, because of the slurred speech and all, we are not able to realize, but later on we realized that they are able to understand symbol jokes and obey the commands. Also, we have to assess the degree of ability to comprehend instructions such as spirometry and postoperative physiotherapy. The spastic gait will restrict the degree of mobility, and pulmonary function test, as in our case, he was unable to do, but there was good motivational status. So the last 3 points were to our advantage, that he had good motivational status, cooperation by the relatives and the patient himself, and we had a good team who could take over multidisciplinary care. And also in this patient, these patients, they have a recurrent aspiration, impaired airway clearance, so we have to affect the respiratory status, and Yes, yeah, there are no conflicts of interest and all the consents were taken from all. And thank you, sir, for giving me this opportunity to present this case.
Apart from having a long-standing hydropneumothorax in a patient with cerebral palsy, there was nothing unusual in this case, right?
There was nothing unusual in this case. There was just this prolonged hydropneumothorax for more than 3 months. The main issue was there were cultures in the growth. Growth in the cultures which were seen after they came out negative, and he was nutritionally improved. As the literature had said, these patients are more prone for airway infections as well as the general systemic infections. They are more prone to catch UTIs also, so we had the best chance at this time.
So the main problems or challenges that you would have faced in this patient is, one, lack of muscular tone to do post-operative physiotherapy. That is important, because unless you get the lung up, it is going to go back to square one. And then of course you say, as you mentioned, nutritional choice. I don't know, many centers don't use epidural anesthesia at the outset because of the chance of infecting the spinal canal. We tend to use epidural anesthesia at the end of the case. Either you put a paravertebral catheter or maybe an epidural anesthesia once everything is cleared. So that is a good practice to do. I don't know whether other people will agree with it. In presence of infection, epidural anesthesia is generally avoided.
Okay.
You can do it at the end of the case.
Yes,
no
we also realized the same problem, and we ensured that there was no systemic sepsis. So we did all the counts, all the cultures, all the blood cultures, and we realized once it was negative, then only. But we accept this, that there is a chance of
not a question of sepsis, systemic sepsis. The very fact, the procedure itself, you can introduce infection into the spinal canal.
Okay.
If you by chance go into the empyema cavity and that leaks into the spinal canal, it is described. That's the only comment. Okay. Thank you very much.
Sir, a question. Point well taken, sir. Sir is actually right in this regard, that any undue infection, systemic infection, has a very high probability in infecting the epidural area and the spinal canal. Also, going through your presentation, I want to ask, you had a 3D reconstruction of the lungs, which was, I mean, was it done just blanketly in all patients, or what was the need to do that?
We have a tendency of going to the CT scan console, and there we had some radiology friends out there who was just curious to show it to us, and finally we saw it, and it was really beautiful. We could assess how the parenchyma would look like and how the other lung vasculature could look like. So we thought it is a good idea to do it in other cases also, because already we have done a CT, and it doesn't take anything extra to get it reconstructed.
It looks fancy, but a normal CT scan tells you almost everything that you need to know.
Yes, of course.
The pulmonary vasculature.
We got the details from
But hats off to your anesthetists. Done a great job. You guys done a great job. Cerebral palsy is a very tough disease to handle.
Okay.
Thank you
so much for giving us this opportunity. Thank you.
Next presenter, if
this morning.
Okay.
Yeah. There were 4.
We have couple of papers, 4 papers, isn't it?
4 papers they haven't reached.
Okay. Yeah. Or if anybody has to present something extempo, sitting on the audience, anybody, madam sitting behind or here. Okay, if not, let us break for tea and we'll organize it. Thank you.